Oh, nice. The birds in the background.
Yeah, that's why I'm sitting out, you know.
Nice.
So, Marion, you are going to cover wide field and conventional both. Or you are just going to focus on any particular, or is it mixed?
So I will talk about wide field angiography, so a little bit in general. So and then about some particular features which are very specific for uveitis in FA. And last but not least, I will talk a little bit about peripheral vascular leakage. And, how much is, so this is a little bit the frame.
Wonderful.
I hope that's okay.
Yeah, I hope
absolutely.
so. And I do hope to see all of you in person someday.
Yes, really.
Hopefully, yes.
It's been too long.
It's been too long. Almost 1 year, nearly.
Yeah. Yes.
Yeah, Taiwan.
Taiwan, yeah. That's right. And you don't see anything happening till next year. I mean, maybe end of next year.
Maybe end of next year, yeah. I think, but as actually we had the Swiss ophthalmology meeting, and this was this was in Rio. So, but yeah, this was actually the only meeting I know which was performed in live.
So how did people sit in the hall? There was social distancing and all?
Completely. So we were really divided into 3 groups, and one group was allowed only to be, we had certain levels, and we were switching all the times in the levels. And you sometimes it was like you had a presentation, but you were completely alone in the room because the people who would have been interested in this particular topic, they were not allowed to go in this area, so they had to stay downstairs, and you actually performed only virtual. So you're in front of an audience room which was completely empty. It was kind of weird, but we had but we had no COVID cases after this event, so it was deemed as a success. it was interesting.
I think we'll start, ma'am.
Good.
I think yeah, it's 5 o'clock, so we will. So welcome to yet another session of up-to-date series by the Uveitis Society of India. And as far as the comments we are receiving from all of you, we are very happy about these series and the comments that you are giving, because they are very focused and they cater to the uveitis specialist, which unfortunately we don't have a whole lot of them, but what we are trying to get is more people learn about it. And during the lockdown, this is the best time available to us to learn from the world experts. And this one is particularly very, very special session because we have with us experts who are young, who are enthusiastic, and from their talks you will realize what wonderful experts both of them are. And I'm really very happy because both of them are members of IUSG and they are doing some great work. And recently we had a beautiful consensus on OCT angio in uveitis by both the experts, and they led everybody, and we are looking forward to many more such proposals from both of them. So Manisha is going to introduce them officially, but to me they are wonderful, wonderful people. Marian and Francesco, I'm personally very fond of too. And then we have panelists I'm again very fond of, Shishir, and of course Mohit. Mohit is in our team, and he's in the retina and uvea at my place, and it's wonderful to have him as a panelist. So with this brief introduction, I would ask Manisha, who's the Secretary of Uveitis Society of India, to take it forward and begin the proceedings of the meeting. Over to you, Manisha.
Thank you, ma'am, and good evening all. So we have another exciting session of FFA and ICG in uveitis today. And we have the privilege of having Dr. Marian Monk and Dr. Francisco Pichi. So Dr. Marian, she's an associate professor at the University of Bern in Switzerland and also the managing director at the Bern Photography Reading Center. She's also an adjunct faculty at the Northwestern University, Chicago, USA, and chief medical officer at the Iserna Therapeutics. She's authored more than 90 articles and a main in disease posterior uveitis. Member of the editorial board of several prestigious such as the IOVS. Today speaking on the photography in uveitis. We also have Dr. Francis, who's an associate staff physician at the Institute of Cleveland Clinic at Abu Dhabi. And prior to this, was also working at Institute Cleveland Clinic, Ohio, and having an exposure to have worked both in Europe. He has a diverse expertise in disease presentations, especially in retinal diseases. He was a part of the European study group that discovered the application of mineralocorticoid receptor agonists for the treatment of CSC. It was something very interesting for all of us. He's also a leader in the non-invasive OT application to study the iris vessels in the various vascular diseases, and his current areas of interest are the use of multimodal imaging in various retinal diseases, and his efforts are in creating objective ways of assessing inflammation to be helping us in managing our patients better. So thank you both for joining us for the webinar today, and Dr. Pichi is going to be speaking to us on indocyanine green angiography application in various uveitic entities. We also have Dr. Shinarayan, who's a senior uveitis consultant at Shroff Eye Center, New Delhi. And we have also a young enthusiast, Dr. Mohit Dogra from PGI Chandigarh, again with a vast experience in the field of uveitis. So looking forward to the session today, and Dr. Marion, over to you, please.
Thank you so much. Thank you so much for the kind introduction. And I may start to share my screen now. All right.
So I would just request everyone to just mute their mics, and maybe we can put them on when we have discussion. We'll just have both the talks first, and then we will take up the audience questions and the discussion.
Perfect. Can you see my screen now? Can everybody see it?
Yes, Mary.
Okay, perfect. So we'll go ahead.
No,
so
no. We saw you, but we can't see the slides. No, sorry.
Okay, that's not good. Maybe let's do it again. All right.
Yes.
Okay. Now you can see it, but now you will, yeah. But not now. You should be able.
Got it.
Good,
got
perfect.
It. Yeah.
Thank you very much. All right. So all the problems have been solved, and thank you very much for the kind invitation. It's a great pleasure for me to present at the Uveitis Up to Date. And I, as previously said, I will talk a little bit about wide field angiography in uveitis. These are my financial disclosures. However, none of them are relevant to my talk today. To give you a brief overview, what I will try to cover within the next 20 minutes and what you can expect to hear from me. So I will talk about wide field imaging in general, and then particularly about wide field angiography in uveitis. Similar, I will show you some diagnostic biomarkers, which you can see in angiography. These are very specific for uveitis. And last but not least, I will talk about the very important topic of peripheral vascular leakage. So when we talk about wide field imaging, we have to be aware that it's very heterogeneously used, the term. So a lot of people talk about wide field FA, and then they talk about ultra wide field FA and ultra wide field FA. But there has been a classification in the guidelines when you can call a picture wide field picture or wide field angiography, and when you can call it ultra wide field angiography. So in order to call a picture or an angiogram wide field angiogram, you have to illustrate and show all 4 retinal quadrants plus the 4 vortex vein ampullae. So if you have a look here at the picture on the left-hand side, you can see here this blue circle, and you can see here in this ICG that all 4 vortex veins ampullae are visible in this picture. So everything which is within this blue circle can be called wide field imaging. So if you can capture this area, it's a wide field angiography and a wide field angiogram. Everything which goes beyond the vortex veins ampulla and are anterior to it can be called ultra wide field imaging. Here we do not have a certain definition because, of course, what you will see is that we have a lot of different camera systems which can perform ultra wide field imaging. However, then the field of view can really vary between 150 degrees to over 267 degrees. However, here there is no definition, no further definition. These are all ultra wide field images. This here is a representative figure showing you what kind of different cameras can actually illustrate and depict retinal areas. And what you can see here in the 20 degrees, for example, you see that not even the whole macular area is depicted. With 30-degree field of view, you can get a nice view of the whole macular area. With 50-degree field of view, you can already visualize the vascular arcades here. And with the traditional 7-field EDTS imaging, which is actually gold standard for all kinds of retinal vascular diseases, you can depict an area up to 75 degrees field of view. The 9-field EDTS grid imaging is not depicted here, but it's particular of interest in the Uveitis Society or in Uveitis trials because it was particularly produced or developed for uveitis. I'm just thinking, for example, of the pivotal trials for CMV retinitis. And with the 9-field imaging, you can kind of capture an area of about 80 to 85 degrees field of view. Then when we look, for example, at RedCam cameras or PanoRed cameras, you are able to depict an area of about 130-degree field of view. And here you see that already all the 4 vortex vein ampullae are visible. So here you can start to call an image wide field image. So 130-degree field of view is already a wide field image or a wide field angiogram. Here is an area which goes anterior to the ampulla, about 130 to 150 degree field of view. And for example, the Claros 700, here it's 500, but the 500 can only do color fundus images and no angiograms. And also the Spectralis wide field lens, at least if you do the peripheral sweeps, are able to capture an area of 130 to 150 degree field of view. And then last but not least, of course, you have the Optomap, which actually is able to capture the widest field of view with only one picture with up to 200 degrees field of view. And these 2 image modalities and these 2 field of view would already be deemed as ultra wide field imaging. This is just one representative example with the Heidelberg wide field lens system and an angiogram performed with it. But you can see here, so this is one central shot without any peripheral sweeps. And what you can see here, that actually you would not be able to illustrate the 4 ampullae. So actually, it's not really a wide field image if you only do one central image. However, if you do the peripheral sweeps, what you're usually doing when you perform wide field FA, you can capture an area of up to 150 degree field of view, and this you then can call ultra wide field images here. Here is another example of the Optos. Optos captures about 82% of the retina. It combines an SLO with an ellipsoid mirror, and as you can see here, you would, if you would perform an ICG, which you will see later on by Francesco's talk, you would be able to see here all 4 vortex veins ampullae, and it would be called an wide field image, and actually as it goes anterior to it, it would be already an ultra wide field image. The Claros 700 size camera is now also able to do angiograms and angiograms. If you do one central image, you would get a wide field image, which would cover about 130-degree field of view. And if you perform two images side by side, then you have an ultra wide field image which captures about 200 degrees field of view. You can already perform montage images up to 7 images, and this would cover up to 267 degree field of view here. With all the, with all ultra wide field image devices, there is a peripheral non-linearity or distortions produced by the Mercator projections of the peripheral fundus onto the flat monitor. And the Mercator projection is actually a cylindric map projection and is usually found and used in maps. And the wider the field of view, of course, the more this distortion becomes evident and clinically relevant, since such effects are most pronounced in the retinal periphery. And for example, the Optomap has developed and validated a mathematical correction for Mercator projection distortions to allow an accurate measurement of the lesions and the periphery here. And as far as I'm aware of, also Zeiss has developed such kind of mathematical corrections that you are able to actually really visualize and quantify the peripheral changes in these images. Perhaps the greatest limitation of ultra wide field images, however, is the resolution, which can be half or less of that achieved with more traditional fundus photographies. So for example, if you look at the wide field lens of Spectralis, you have a resolution of 10 microns per pixel, and the usual resolution of a 45-degree lens, for example, would be 5 microns per pixel. In Optos, depending a little bit on the settings, you can have a resolution of 11 to 14 microns per pixel, and Zeiss actually has the best resolution for these wide field images with 7 microns per pixel. This is important if you want to depict, for example, the foveal avascular zone together with the peripheral changes of, for example, peripheral vascular leakage, because you can't assume that when you do an Optos image that you have a resolution, that you can look at the foveal avascular zone with a resolution of 14 microns per pixel and also at the periphery. So here you would have to use a different lens system. And then, I'm sorry, this is my phone, probably my parents, and also look at the periphery. So you would have to change. A resolution up to 7 microns would probably also enable you to look at the foveal avascular zone as well as the periphery. So it's kind of what you really want to see. So this is really the main resolution or the main limitation of wide field imaging here. When we look specifically at angiography in uveitis, there are similar to OCT characteristic diagnostic signs which you make think of that there is some inflammatory condition present or something inflammatory going on here. And actually, FA signs in uveitis, when you look, for example, there can be only hypofluorescence or hyperfluorescence, and increased fluorescence can be either due to 3 main mechanisms. So you can either have leakage producing pooling, which pooling takes place if it's pooling in a space, in a free space, or staining, which would be actually hyperfluorescence in a tissue. Or you can have increased transmission of fluorescein due to fundus atrophy with removal of the RPE producing large hyperfluorescent area, or due to small windows defects produced by areas of RPE defects. Or last but not least, you can have hyperfluorescence due to presence of abnormal vessels like retinal vessels or choroidal neovascular membranes. You can also have decreased fluorescence, and here decreased fluorescence can be either due to transmission decrease, blockage, or due to filling defects like a vascular delayed perfusion or non-perfusion. So actually, it's very simple because you can only have 2 kinds of presentations here. One very characteristic sign which would make you think of uveitis is this phenomenon of early blockage or early hyperfluorescence in the early frames and late leakage in the active lesions. Although it may be characteristic for any kind of inflammatory conditions, it's not very specific for a disease, and you can find it in a lot of different diseases, which you will see in the upcoming slides. For example, here you have a case of early blockage and late leakage in patients with a plaque-weight chororetinopathy. In this case, it's a case of AMPI. You can find this in AMPI, in persistent plaque-weight, or in relentless chororetinopathy. But actually, where does this kind of pattern come from? Actually, you have inflammation of the core capillaries, mostly manifests by non-perfusion, with the consequence that the outer retina becomes ischemic, which in turn produces leakage from the reacting inner retinal capillaries. And like you see here in the early frames, then you have the hyperfluorescence, and then in the later frames, you have the leakage from the inner vessels, which cause this hyperfluorescent pattern here. But again, as said, this is not very specific for a certain disease, and you can actually find it in all kinds of diseases which can cause ischemia or inflammation at these areas. Here you can see another example of a granulomatous disease in a patient with a tuberculoma, and you can see when you look closely that there's an early hyperfluorescence and a late leakage. I mean, of course, it looks completely different, but the pattern is the same. But of course, the reason for it is completely different. But again, it's not pathognomonic for tuberculoma. It can also be seen in other granulomatous diseases, like for example in sarcoidosis. And when you look here, for example, you have a patient with a very early hyperfluorescence and a late leakage. And here you have granulomas due to sarcoidosis. And of course, if you compare the pictures, again, a completely different picture. But if you describe it, you will find early hyperfluorescence and late hyperfluorescence and late leakage. You can also find these patterns in other granulomatous diseases, like in VKH or sympathetic ophthalmia, for example. But usually FA typically demonstrates in these kind of diseases with multiple hyperfluorescent leakage sites at the RPE during the venous phase that persists into the late frames. And these multiple hyperfluorescent lesions correspond to the small breaks in the RPE, which you can sometimes, when you look very closely, see in the OCT. And in severe cases, you may see the pooling of the dye into the subretinal space, thus into the area of the exudative retinal detachment. The less common appearance of VKH or sympathetic ophthalmia in FA is that of the early hyperfluorescence and late staining or leakage, similar to that what you can see here, or similar to that what you can see in AMPI. The status of the RPE overlying the Dahlen-Fuchs nodules or the granulomas or the integrity of the core capillaries is that what determines the fluorescence on these lesions. So you have blockage of the choroidal fluorescence. This may occur when you have an intact dome of the RPE, which contains the cellular element of the Dahlen-Fuchs nodules. And then you have a gradual accumulation of these fluoresceins into the Dahlen-Fuchs nodules. And then this may produce this focal hyperfluorescence, what you can see. The degeneration of the RPE or overlying the granulomas or the Dahlen-Fuchs nodules may allow fluorescent dye to permeate focally into the RPE and gradually then accumulate into the subretinal space. So to understand, in order you can see all these kind of different patterns in this disease, it really depends on how the core capillaries and how the RPE looks like. If you have an intact RPE with accumulated granulomatous effects, you can also find this specific pattern of early hyperfluorescence and late hyperfluorescence, like you see here. But of course, we also have patterns in angiography and in the angiogram, which are really pathognomonic for one disease in uveitis, like the Wreath-like pattern in mutes. And here you see an early hyperfluorescence with minimal late staining in the late frames. And if you compare it in multimodal imaging, you see that these lesions correspond to the dots and spots you see on OCT. Another very pathognomonic sign or important sign for uveitis is vasculitis. But here you have to differentiate between the leakage within the retinal layers and the leakage coming from the core capillaries. In the core capillaries, the fluorescein dye can freely extrude through the large fenestration, and this causing choroidal background fluorescence. So the background fluorescence you usually see also in a healthy angiogram. However, if you have areas of inflammatory foci, then these areas will appear hyperfluorescent on this angiograms. The retinal vessels are completely different because they have tight junctions and they are not fenestrated. So usually there is no possibility for the dye and the protein to actually get outside of the vessels. This is only possible in the presence of inflammation, and then you can see this characteristic leakage, which is very sensitive for inflammation and activity. Vasculitis should not be differentiated only in terms of whether it's the choroid capillaris, choroid, or retinal vessels affected. You should also differentiate it what kind of retinal vessels are affected. So whether mainly the veins are affected, mainly the arteries are affected, or mainly the small capillaries are affected. Because from this you already have the information, or you may already get the information or an idea what probable underlying causes may be the reason for your disease and for your inflammation. For example, if you have phlebitis, so mainly the veins affected from the inflammation, you may think of bird shots, multiple sclerosis, but you may also think of HIV, postplanitis, Behçet, TB, but also sarcoidosis in eels can cause this kind of phlebitis. Of course, it's not only important to look at the angiogram here, you have to look at all the information you have, and based on this, you can already make a very tight differential diagnose what you're probably dealing with. For example, this is three exemplary examples of 3 different birdshot patients, and you can see the different severity of the periphlebitis, but it's very characteristic. And if you see this kind of periphlebitis, you should really think of birdshot, of course, together with other findings in imaging and from your exams. And from the blood count and blood examination. But again, you should still think of sarcoidosis, CMV, retinitis, and syphilis, of course, depending on the other changes you see. This, for example, is the case with the focal periphlebitis, which was then diagnosed with syphilis, and you can see here that only the veins focally are affected here. A special situation is represented by a particular vasculopathy, the so-called frosted branch angitis, which only mainly affects the veins, with thick perivascular sheathing, which is not only visible on angiogram, but also on fundus examination. And frosted branch angitis can be associated with herpes or CMV, especially in the context when you already have AIDS. As well, you can see it with toxo, lupus, Crohn's disease, but also with leukemia and lymphoma. But it can occur also idiopathic, as in these 2 different cases. Peripheral vascular leakage can mainly affect the veins of the small capillaries, and it's also pathognomonic for different diseases. And if you see it, you should think about it. Very important is postplanitis and multiple sclerosis. You will very often find this peripheral vascular leakage there, but also in Lyme disease and inflammatory bowel disease or sarcoidosis, you may see this kind of pattern. Here on the left-hand side, you see a representative example of a patient with postplanitis, and here a patient who was diagnosed with multiple sclerosis. These are another 2 examples of a patient with postplanitis with associated secondary complication of a cystic macroedema here, and different severity stages. Arteritis, again, should make you think of iron porn, systemic vasculitis such as lupus, Behçet, but also Susac. For example, here are 2 representative examples. On the left-hand side, you see a patient with arteritis and occlusive vasculitis in lupus, and right next to him, a patient with Behçet, also with occlusive vasculitis. These are 2 representative examples of a patient with Susac syndrome. Here, more subtle changes, and here you can see also some occlusive components. As soon as we implemented wide field angiography in our clinic, we saw a lot of this peripheral vascular leakage. And the main questions we asked ourselves, at least the uveitis specialist, how much is tolerable? So is it actually something you have to treat, or can you just observe it? And when we look at a lot of retrospective data or papers which had a look at it, found that if you see peripheral vascular leakage, actually you change the management in about 50% of the cases. And we also know that the leakage you see here on the wide field angiogram, are highly specific and sensitive for clinical activity. And we also tried to implement it as a kind of quantitative measurement for multi-center trials, but also for clinic, in order to follow the patients more objectively in terms of their disease activity. We see, for example, that with peripheral vascular leakage, the likelihood to initiate or increase treatment is 4 times higher. However, when we look then at the outcome, a lot of papers have shown that there is no difference in treatment outcomes. But we know if the peripheral vascular leakage is associated with capillary non-perfusion of a larger area with at least 3 clock hours involved, we know that it's associated with the development of neovascularization. So large areas of peripheral vascular leakage and associated non-perfusion should be definitely aggressively treated, that you can prevent the development of neovascularization. But also other secondary complications can occur from this peripheral vascular leakage and disease activity, like in this paper shown from Francesco, so he will talk later on ICG, where you can see that due to this activity, you can see the development of peripheral retinoschisis. But not only peripheral retinoschisis, also vasoproliferative tumors can occur and develop in the presence of peripheral vascular leakage and active inflammation and disease activity. And these kind of inflammation and peripheral vascular leakage should be definitely aggressively treated in order to treat also the secondary complications appropriately. So to conclude, it's definitely nowadays an indispensable image modality in our uveitis clinic. It's important for the assessment of secondary complications and especially for peripheral vascular leakage, but we still have a lot to learn, especially what we have to treat and what we can just observe. So thank you very much for your attention, and I'm looking forward to the talk from Francesco and later on to your questions.
Thank you, Dr. Marion. I think that was an excellent talk. And highlighting the various patterns that we get on fluorescein angiography. So let's go over to the next talk by Dr. Francisco, and maybe then we can take up the audience questions and have an interesting discussion.
Thank you. That was great, Marion. So can you see me? No, I mean, you don't care about me, but can you hear me and see my screen?
Yeah, we can see your screen.
Perfect. So first of all, thank you very much for the invitation. It's really great. I wish we could do it in person, but for now I'm going to talk about ICGA in uveitis. These are my financial disclosures. None is really relevant to the present talk. Now, you have seen from Marion's slides and from this slide as well that ICG molecule is basically green and big. It's something that in uveitis we use to look at the choroid, to highlight choroidal lesions, and to look at some features of white dot syndrome in posterior uveitis. But to be honest, when I was asked to give this talk, I was a bit reluctant because I suffer from this disease. The Bruce Banner disease. Now, Bruce Banner was a scientist who was concentrating on studying something called beta rays, and he was really putting his life effort into it. And as Bruce, I've been concentrating for the past years on these non-invasive imaging modalities. And I've been fighting, like Bruce Banner has been fighting his green alter ego, the Incredible Hulk. I have been fighting through these non-invasive means like OCT and OCTA. I have to admit, I've been fighting ICG in uveitis, not really fighting, but trying to replace it. For example, you've seen from Marion's talk that AMPI is a disease where ICG is very important, but is still fundamental for the follow-up of patients. Now, this is a patient with the AMPI. You see from ICG that there are multiple hypofluorescent areas, which means ischemia of the choriocapillaris in this case. This is the other eye of the patient. And you see that in this patient, OCT angiography at the level of the choriocapillaris highlights the same lesions perfectly. So we may argue that ICG could be important for the diagnosis, but not so much for the follow-up. But then, like Bruce Banner, I have learned to live with the green side of the invasive exams that we have. And from ICG, I've learned 4 very important lessons that I would like to share with you. Now, what is the lesson number 1? Well, it's mutes basically, and through mutes, I've learned something very important that was really overlooked on ICG and how it interacts with the eye. Now, mutes is white dot syndrome. You know it very well. Classically, there is a bit of granularity of the fovea, some lesions, whitish, yellowish lesions that are quite faint sometimes on fundus photography. You saw the rat-like patterns on FA through Marion's slides. On autofluorescence, they are hyper autofluorescent. So it means that the RP is indeed involved a bit. And then classically, ICG shows hypofluorescent of these lesions. So for long times, it would say that mutes is a disease of the outer retina, RP, because the RP is affected, but it comes from the choriocapillaris. However, through OCTA, and OCTA of the choriocapillaris, we have learned and showed that there is indeed 0 ischemia in the choroid and in the choriocapillaris in mutes. And furthermore, if you use unfast OCT at the level of the RP, you see that these hyperreflectance on the unfast OCT correspond perfectly to the ICG. So why is that? Well, this is the normal retina and choroid. When you inject the green dye, it goes firstly in the choroid, then in the choriocapillaris. But this beautiful paper that you can see on your right-hand side, that's shown that the normal RP catches some, not a lot, but some of the ICG dye. And what happens when the RP is altered, like it can happen in mutes, for example? Well, the altered RP cells do not catch the green dye anymore, so they appear hypofluorescent. So this ICG appearance of mutes, it's not really a disease of the choriocapillaris. It's not ischemia. It's just due to the RP, which is not intact anymore. It's bumpy. It's not catching the green dye as it should do. And this highlights very well. On your left side, you have patients with mutes, ICG, hypofluorescent lesions, and the same lesions, they are mirrored very, very well on the unfast of the ellipsoid and the RP. So the take-home lesson that I have learned from mutes, I don't care at this point if this is a disease of the RPE or the ellipsoid zone. What I've learned is that RPE catches some of the ICG dye. And when the RP is disrupted, it doesn't catch it anymore. And if we can sometimes mistake some of those hypofluorescent lesions for ischemia of the choriocapillaris, but they may be not. Now let's move to lesson number 2. This is what I've been doing for the past year. I'm sure, especially in India, you all deal with granulomas in the choroid. In TB patients, in sarcoid patients, in VKH patients, ICG can be very important to look for choroiditis such as this, because granulomas are occupying space lesions, and when you inject the ICG dye, it doesn't go inside the granuloma, so they appear as hypofluorescent dots, masses in the choroid. But then again, I have tried through OCTA to dismantle the importance of ICG in granulomas of the choroid, because after all, granulomas are lesions that occupy space, and so the flow it's not really great in those areas, which means that OCTA is actually able to highlight those same lesions. See here, this is a granuloma in the green square on ICG, mirrored in the OCTA of the choroid, and confirmed through the through the eye, and same for this one, confirmed on EDI. So what we've done together with the Alessandro and his group in Italy is show that there is a perfect correspondence on ICG and the OCTA of those hypofluorescent lesions that are granulomas with the flow voids on OCTA. We did it first in a cross-sectional study, and then we looked at what happens when you treat those patients. Now we have, this is a patient with sarcoidosis, OCTA at baseline and the corresponding ICG at baseline. Treatment, 3 months of treatment. OCTA, there are less granulomas, they are smaller. And ICG, there are less hypofluorescent lesions, but then there's something else. Those lesions become hyper in ICG. And I looked at the literature, there's nothing about it. And I'll show you another example. Patient at baseline, let's look at this granuloma here on OCTA and ICG, perfect correspondence. The flow void corresponds to the hypofluorescent lesion, and EDI confirms. Then you treat the patient, and you see they go away completely on OCTA, so there is no mass occupying lesion, but then it becomes hyper in ICG. So this goes against everything that we've been taught. What we've been taught, especially by Herbert and his group, is that at baseline, this is an OCTA of granulomas. What happens at baseline in normal granulomas? In ICG, they are hypo in the intermediate, and then some of them, they disappear in the late, which means they're not full thickness, or some of them, they persist, which means they are full thickness. But then with these prospective studies, we've learned that they do improve on OCTA, they do decrease in ICG, but some of them become hyper, which I've never heard of it. And then 3 months, same patient, complete disappearance on OCTA, complete disappearance in the intermediate phases of ICG, and some of them, they are still present. So I've learned a lot actually from ICG in granulomas from this prospective study where I was actually trying to undermine ICG to use OCTA better. So I've learned that there are 3 patterns of healing. One is the granuloma just heals without leaving anything. On ICG, you see intermediate and late, it goes away completely. The second pattern is it takes some more time. So maybe it was a big granuloma in the beginning. As you can see on your left side, it was a hypo both in intermediate and late. So probably a big space lesion, space occupying lesion granuloma. And the second pattern, they just become smaller. So smaller, they disappear in the late, they're still present intermediate. So probably it's not a full thickness, but it's healing. And then the third pattern is that they are present in the intermediate phase of ICG and they become hyper. So probably our theory is that these are granulomas that are slightly older. They were there before and they are forming a scar which is pulling the choriocapillaris above, which is catching more ICG dye, and there is this hyper fluorescence. So this is really something that ICGA has taught us about granulomas. Now let's move to the third lesson. There is a beautiful paper by Carl Herbert that showed that when you have a toxo lesion, you should do ICG because there are satellite lesions all around, and even not just around the main lesion, they can be actually everywhere. And this is great. This is something people are not doing enough. And this is something that I've tried to undermine this as well through OCTA. This is the same patient. OCTA of the retina shows of course, the flow void of the retina because it's a retinochoroiditis. But then you move down in the choroid and you see that those satellite lesions you can identify very, very well without injecting any dye and just by doing an OCTA. But then I learned something else. You heard from Marion that toxo can be associated also with perivascular phlebitis, can be associated with sheathing, candle walk sometime, but with something else, those Kyrieleis plaque that were described in 1933. And they've been called with multiple names during the years: periarteritis, arteriosclerosis, immune cells within the vessels. But they are indeed quite different from frosted branch and from sheathing. And through ICG, we were able to demonstrate what they are. Now let's look at a couple of photos. Of course, when you look clinically, they seem like calcific, but they're not. They are mainly located in arteries. So this is the main difference with the, for example, sheathing or frosted branch. But there you don't get a lot of information. What you get information from is ICG. ICG stains those plaques both in the early and in the late phases. And so you already can understand that ICG is circulating, it's big, it's amphiphilic. So if it's staining, then it means that this is not peri, which means around arteritis, it's inside. It's like an endothelitis. An ICG, amphiphilic, is able to bind to the inflammatory proteins of those endothelitis plaque. Let me show you this example again. That's the same patient as before. And you see, this is the ICG. It's staining the inflammatory plaque perfectly. And even in the late phases, very late phases, stays like this. And you scan with an OCT through it, and you see both here and here, you see those round vessels with an hyper-reflective wall, which means something is inside the wall infecting it. And this is the infection in the endothelium, probably. So through multimodal imaging, especially through ICG, we have learned what they actually are. Because if you look at the FA on your right, the part that it's highlighted in with the ICG is actually not leaking, while the rest leaking here can be a sheathing, for example, of the vessel, because sheathing is affecting the full thickness of the vessel. And when you find them, you should always look for them with ICG because they should disappear completely with the treatment. So Kyrieleis, those small plaques, they're not periarteritis, they're not arteritis, they are indeed endothelitis, so they affect the endothelium. One last lesson I've learned, and this is something very important, probably you don't see a lot of these Burchard cases in Italy. I've stopped seeing lots of them in the Emirates, but it was super common in the US. So we know that Burchard is a disease where ICG is showing more and more of those hypofluorescent lesions that are the Burchard lesions. They're not granulomas, of course. And this is a very important disease where ICG for me is fundamental. But why? Because it's actually showing us that ICG Burchard is a completely disease from FA Burchard. This is a patient with Burchard, okay? And we do FA and ICG. You see there is a mild leakage, but as Marion said, should we treat this leakage or not? Not really. There are hypofluorescent dots in the ICG on your right. So at this point, the patient was deemed basically slightly active on ICG, but inactive on FA. So he wasn't treated and comes back 3 months later. There is more leakage on FA, and there are more hypodots in ICG. At this point, this decision was to just proceed, since the patient was more active, proceed with intravitreal triamcinolone, which took care greatly of the leaking. But then there are more and more hypofluorescent dots on ICG. So it means that the choroidal component of the birdshot lesion is progressing despite the intravitreal triamcinolone. I will show you at this point the patient was started on CellCept, and I will show you why we used more immunosuppressant for the choroidal component of birdshot. Now this is a patient, 2020, no inflammation and no leakage on FA, and it comes back six months later, same 2020, no inflammation and no leakage on FA, but see how many of those hyperfluorescent dots on ICG. So it means this patient is having an active choroidal inflammation from birdshot. And if you treat those patients, like with usually I used to give CellCept, and they do improve a lot. You see this patient just in 3 months, there are in 80% of those hypofluorescent dots disappear completely. So this birdshot is a disease where ICG is paramount, especially wide field, in this case ICG, because if an FA is not leaking, it doesn't mean the disease is inactive. And actually, I tend to disagree a lot in a conference with Professor Herbert. I love him, but he was right, especially about birdshot. There are two diseases progressing parallelly. And with this, I thank you very much for your attention.
Thank you, Dr. Francesco. Again, that was a very nice talk, and I think you made ICG sound very simple, but I'm sure that many of us don't find it all that simple to interpret in our clinics. So at the outset, I just wanted to ask you one question, that many of us still don't have ICG available in our clinics. So are there any specific disease entities which you would think where ICG would be indispensable in your practice?
So if you have the luxury of having maybe an OCTA, then birdshot, but not a lot. So the point of my talk is, I don't think ICG is indispensable in a uveitis practice. I think we're going towards an area where we will ditch completely, or most of the time we will not use ICG and use OCTA, which is becoming more and more affordable and available in various clinics. And with the OCTA, you can get out with it very, very easily.
Right. So maybe I'll take up this next question, which we have from one of the doctors, Dr. Shrikant, where he says that he gets a lot of referrals from his medical retina colleagues regarding peripheral vascular leakage in ischemic areas in diabetic retinopathy, and they refer them as inflammatory. So is there any way of differentiating a non-uveitic inflammation due to ischemia from true uveitic inflammation? Maybe Dr. Marion, you can take on this question.
Yeah, actually, of course, there's inflammation, because where you have ischemia, there's also inflammation going on, because, I mean, you have all these pro-inflammatory cytokines being released there. So this is why you also see leakage. But I mean, you have to look at the whole picture, and if you have a hot disc and you have peripheral vascular leakage and no microaneurysms, no other ermas or any other signs of any other retinal vascular disease, you can be you can think it's uveitis. However, if you have microaneurysms there, no hot disc, and no other signs of any other retinal vascular diseases, or some kind of hemorrhage or something, you may rather go into the direction of diabetes. Yeah. So it's you always have to look at the whole picture. Yeah.
So there's Dr. Francisco, you'd like to add anything to that?
No, I agree completely with Marion. Unfortunately, we do see a lot of those patients, especially in my region right now. Type 1 young diabetic patients, they are completely out of control, and they do look like uveitis. They have this leakage, areas of non-perfusion, neovessels. You have, of course, to look for cells. So I always look for cells, and if there are none, of course, Marion, you're right. If there are none, then you tend to go towards diabetes.
We see a lot of type 2 diabetes. Maybe Mohit and Shishir would like to give their comments on this.
Well, I think it's very good point that Dr. Marian has raised, has pointed out that if you see a hot disc without neovascularization, then you are dealing with an inflammatory pathology. One thing very interesting I found, and Dr. Marian also pointed out in her talk was, and we saw one of her ultra-wide field images having CNP areas in the periphery and macular edema in the center. So you can have retinal vasculitis with peripheral non-perfusion that not only causes neovascularization as one thing, but also causes cystoid macular edema. So two things, a center effect from a peripheral ischemia can also lead to CME, and that would respond to anti-VEGF rather than to a steroid. So, you know, we are learning so much more by having the information of the periphery. What will you say to that, Dr. Marian?
Yes, so that's correct. The papers I'm aware of, they haven't shown an association between peripheral vascular leakage and the presence of cystic macular edema. However, as you have pointed out, the presence of capillary non-perfusion can cause cystic macular edema, so there is an association. Yeah. And as you said, the question is, should you treat inflammation first, or should you rather go then for the areas of capillary non-perfusion and treat this? I mean, we know from the retina specialists that they tried to use targeted laser treatment to treat the areas of non-perfusion in, for example, retinal vein occlusions or in diabetes, in order to decrease cystic macular edema, and actually this did not work. Yeah. So yeah, I think there's still a lot to learn. Yeah.
So we
can I ask a question?
Mohit,
regarding all this, Marion, do you think that the asymmetry in such cases where you think it's diabetes or can be inflammation, do you think the asymmetry between the two eyes can be a telltale sign?
I never thought
Not
about
always,
it.
Francesco. Not always. Diabetes can be asymmetric too.
Yeah.
So the thing might vary between the two eyes, but diabetes behaves strange sometimes. Mohit, would you like to add anything?
Absolutely. I think most of the points have been covered well. I would just like to, if I can, quickly sum up regarding the peripheral leakage seen on wide field angio in diabetics. I think we must understand that from our basic knowledge that microaneurysms are the first clinically detectable sign of diabetic retinopathy. It would be extremely rare, if ever, that you would have absolutely no microaneurysms and leakage in the periphery. Second point, I think Dr. Francesco brought out absolutely fine, and which was I think needs to be driven home, is that a clinical exam, if it shows presence of cells of whatever amount, either in the anterior chamber or more importantly in the anterior vitreous, I think that pretty much tilts the balance in favor of a uveitic entity. Also, I think one thing which I think also has to be thought of is, especially with the work done by Dr. Antonio Capone and Dr. Dressner, in which they've actually looked at wide field angiographic leakage in normal people. So 20%, so 1 out of 5, at least in their paper, and all of those were apparently normal asymptomatic individuals, had peripheral vascular leakage on wide field FA. Now,
ultra wide field.
On ultra, I'll rephrase that. Yes,
yeah,
on ultra wide field FA.
Here.
Yeah.
So yes, absolutely. After Dr. Marian's talk, we have to be particular about that. So I think that has to be taken with a pinch of salt as well. That on ultra wide field FA, even asymptomatic individuals in their cohort showed peripheral leakage, especially temporally and infratemporally, which is and that I think is also to do with the angle of the ellipsoid mirror, which is right there in the Optos machine. And that has been, at least what the company says, corrected to a large extent in their newer model, in which they've actually now kind of, it's a little more Polaroid, and hence the images that you get are also better. And they claim that the so-called leakage in the periphery that's happening normally is a lot less seen now. But I think it should be kept in mind also that it's seen normally.
So, Mohit, are you trying to tell us that you can have this as a normal finding in the
Absolutely, absolutely, ma'am.
Very extreme periphery, Manisha, yes.
Yeah.
But I think what Marian has said beautifully, the context is very important. You know, you are seeing a diabetic patient, it is non-proliferative, there's nothing much happening. Even if you are seeing a little bit leak in the periphery, you know, you just need to follow that up and see how it evolves. And this is very unlike uveitis. For example, if you were following up a patient of Behçet's and you are thinking of reducing the immunosuppression and you are seeing some leak in the periphery, you would pay more attention to that. Isn't that, Mohit? What would you?
Absolutely, absolutely, ma'am. Absolutely. I think
context is absolutely
important. Context is important, ma'am. Absolutely.
And I think we've also seen these cases where you have a large amount of peripheral vascular leakage. Based on this large amount of peripheral vascular leakage, you increase the treatment and actually nothing's happening. Yeah.
Nothing happening.
Yeah. And then you think, okay, should I go back or should I treat even more aggressively? Yeah.
You remember Marian Dilraj showing the cases like, would you treat it? If you don't treat it, still 2 years down the lane, nothing happens. So some of these things, I guess the context is important.
Also, I feel.
Yes, Manisha, over to you. Okay, please.
I also feel that, it is a composite imaging and not just looking at one particular thing. Now, if you are in a dilemma that it's a uveitis case or a diabetic case, I think you should look at the choroidal thickness and the pattern of choroidal thickness. We have evolved with SSOCT, self-source OCT. I don't think diabetes would have much changes in the choroid. But when you are looking at choroidal thickness in a patient of uveitis with retinal vasculitis, I think you're going to get different patterns. And I don't know whether, Francesco, you have done any cases of retinal vasculitis or peripheral vascular lesions where you have injected ICG as well as fluorescein and you find a different pattern. Because in diabetes, I don't expect much changes in the ICG, but you would have something in retinal vasculitis.
No, I have to say I didn't. It's because, ICG can have a bit more side effects in terms of reactions for the patient. So no, never done, but you're completely right. Absolutely.
So by the way, I have a WhatsApp message for both of you, Marian and Francesco, from Manfred. Saw both the lovely talks. So he's complimenting you both. So just wanted to let you know.
Thank you so much.
Yes,
many greetings back.
So I just would like to understand that when you are ordering FFA and ICG, I mean, maybe a comment from all of you, that would you prefer doing the FFA first or the ICG first? Does that really make a difference in the order that we do both the investigations?
So in our clinic, we start with the ICG, but it's just because usually, you take the late frames at 20 minutes, and so you can actually compress everything in the 20 minutes. So this is why we start with the ICG. But I think it's rather a thought about how to more efficiently do it. I don't know.
For me, together at the same time.
Yeah, together.
For me also
we start with ICG.
It depends. I don't think it makes a big difference. Yeah.
And also, I've heard a few people say that you should actually be avoiding any dye test or an invasive test when you have an acutely inflamed eye, because the dye itself can cause some element of increase in the inflammation in the eye. So you should actually be putting the patient on steroids or immunosuppressants and then probably do these dye investigations after a week, 10 days. So do you really agree with this concept? It has any bearing on it?
I don't see the point. I can't really see why it should increase the inflammation.
Why should it? No.
Yeah, there's no pathological reason.
Dr. Shishir?
Yeah, I mean, we did believe that, you know, a little bit of an extensive leakage when you see an obvious retinal vasculitis, that is particularly for obvious retinal vasculitis and no other pathology. Supposing you're looking only for a choroidal thing like VKH or something like that, then it's not important. But if you have got an extensive retinal vasculitis with macular involvement, you're obviously seeing that. We have refrained from doing fluorescein angiography in our own setup, but in the very initial phase.
Okay.
Yeah, we feel that an extensive amount of dye can be irritative. We know that when the fluorescein gets extravasated in the skin, you get a very severe reaction. So you have an extravasation of the fluorescein dye into the retina, and it will act in the same way as an irritant. We use that same logic here.
Dr. Marion, any thought on that from your side?
No, but it makes sense, and I mean, I really never thought about it. I really have to admit,
so this is particularly for extensive retinal vasculitis, like, you know, frosted bite, or you're seeing an obvious.
Maybe Shishir, the barrier is broken.
Yeah.
You know, maybe the barrier is so much broken that the dye will come out.
Yeah, and cause irritation there.
Actually, I just had one thing to comment, just, you know, thinking out loud. So if a young patient, let's say a young girl, gets a stroke and, you know, goes to a neurologist would order a CT angio, and, you know, a CNS vasculitis, I think, would be one of the top DDs for that patient. And, you know, the neuroimaging would most likely show, you know, a lot of changes in vessel walls and stuff like that. So just thinking out loud, I don't know how
we can see the retinal
inflammation. How can that kind of
yeah, but on the other hand, you need it in order to illustrate it and show it. While when you have an extensive vasculitis, you already see it when you do the fundus exam.
Yeah, that's the difference.
I would, Manisha, we have a lot of questions here. I think we should start taking them, otherwise we'll miss out on them.
Dr. Francisco, there's one question that why on ICG specifically see in mutes, why are they not seen in other disorders of the RPE? Any specific reason for that?
No, I'm sure they are seen in other disease of the RPE. We're just not doing ICG in isolated disease of the RPE. For a long time, it was just misdiagnosed in mutes. Not misdiagnosed, but we were not sure where was the area of involvement. So that's why we were getting ICG all the time. Now, for disease specific of the RPE, would you get an ICG? No, not really, because you are subjecting the patient to a risk. So I think that's the main reason, but I'm sure, and if you read the paper, it's an amazing paper. If you read the paper by Chang, and it explains very, very well. I'm sure if we started doing it in just disease of the RPE, we would see the same pattern of hypofluorescence.
So another question for Dr. Marion is that we've all grown, understanding or listening to that we get this typical ferning in Behçet's disease. So what is the reason behind that ferning that we see on an angiography in Behçet's, and is that really particular for Behçet's, or do we see it in other entities as well?
No, so it's not specific for Behçet. You can see it in other diseases like in pars planitis. I think I've shown a case where you had a pars planitis and it had this kind of peripheral capillary ferning effect. You can also, I think it's also described in birdshot cases even that you can see this kind of presentation. It's actually when you have kind of peripheral vascular leakage, mainly affecting the veins, and you have a lot of leakage with some corresponding non or decreased perfusion, then you can get this very characteristic ferning sign. Yeah.
And I think related to that, there is a question from Dr. Biswas, who's asking, do all peripheral vascular leakage and pars planitis need treatment? I would ask all the four panelists to give their opinion one by one.
Okay, I'll start because of the two papers. Now, before writing those two papers on the schisis and on tumors, I would have said no. And it depends on the amount. You can tolerate some leakage and then follow the patient. But there we reached a point where really you get complications. And in the schisis paper, we showed that by treating the leakage, the schisis gets much smaller and sometimes disappears completely. So I do have a tolerance for some peripheral leakage, but when you see it increasing and increasing, then I start treating.
Yeah, I'm always asking myself. Yeah, I'm always asking myself if I would be the patient, would I want to be treated? And if I have no secondary complications like cystic macular edema and optic nerve head swelling, and I know that if you treat, for example, if a peripheral retinoschisis occurs or some other secondary complication occur, it's still kind of reversible, and I get regular observation, I may be prone to, you know, stick to no treatment and observation. But I agree. I mean, if peripheral vascular leakage is there is a lot and it's very active, then I would treat it. But I would not treat all. But I haven't written this in papers. So.
Yeah.
For me,
Dr. Biswas is asking, sometimes
Yeah.
you see it in anterior uveitis as well. So would you
I
treat
think it
that?
will depend on the age of the patient. If it's a child, if it's a 12, 14, 15-year-old child, we are dealing with a complex disease. No need to tell Professor Biswas, he has the largest number of children.
I know he's making fun of us.
Yeah, he's making fun of us. He's testing me out, I feel. But if it's going to be a child, 10, 12, 14-year-old with vasculitis, I'm going to treat him through the younger years. Once he's growing, become an adult, at that stage, I can think about it. Also, if I'm deferring treatment, I'm going to have a very close observation with OCT to look for. Then if macular edema develops, then I'm not going to wait at all. So it will depend on the age as well as the OCT changes for me.
Mohit?
Absolutely. I was actually about to say the same thing as with Dr. Chisham. I think my tolerance of treating for a kid would be lower, primarily because of two things. A, he has a longer life, more chances of chronicity. And also they have, it's been shown by Dr. Foster's work that they can land up with two complications, pediatric intermediate uveitis a lot more than adults. And one is vitreous hemorrhage and the other is tractional peripheral retinoschisis. There's a higher incidence in the pediatric IU age group as compared to adults. And I would like to believe that since they have a longer life, a peripheral tractional retinoschisis might not mean too much if you're, let's say, in the elderly age group, but there are more chances of the fibrosis going up, leading on to maybe a break or epiretinal membrane, requiring some kind of intervention. So I think the threshold for kids needs to be considerably lower.
I have an 8-year-old.
They start getting better when they reach about 18 to 20 years. And the need for immunosuppression just goes down.
No? I have an 8-year-old child with pars planitis, which we did fluorescein angiography and had a typical ferning pattern. I got HLA-B51 and that came out positive. So, we are able to pick up, even in intermediate uveitis, the presence of Behçet's disease.
Okay, Manisha, please.
Yeah, so there's another interesting question by actually Dr. Manfred, who says that if you are seeing staining in 3 peripheral quadrants in intermediate uveitis, would you label that as an active disease and would you say that it warrants a treatment despite a 20/20 vision and no CME? There's no occlusion, no neovascularization, but do you still label this as an active disease requiring treatment?
Staining or leakage?
Or leakage.
Well, he has written staining in 3 peripheral quadrants.
I would observe.
If it's staining or no active leakage, I may be also prone to observe. But I think I would again observe very closely in the beginning, and if I see some changes.
Manfred is saying leakage.
Leakage. Then I would treat.
Yeah, me too.
So we are reaching a stage of lower tolerance for inflammation. Is that the take-home message?
Absolutely. Once you know it is inflammation, then there is zero tolerance for any kind of, like Francesco showed those beautiful ICGs, which had a subclinical disease that you could not pick up anywhere else. But if you leave it there, it progresses. So once you are sure you are dealing with some kind of inflammation, then you should have zero tolerance. The question comes when you are not sure what you are dealing with. But if you know you have a sympathetic ophthalmia or birth shot or whatever it is, then it's a zero tolerance.
So does that
Yes,
also
Manisha, next.
So does that mean that if you have a patient of intermediate uveitis, you would step up the treatment, the ongoing treatment, if you see that an activity is there in the periphery, or you would just label it as a stable stage of the disease?
Can you repeat one more time, because it was just interrupted? So if I see an increase in the...
If you see a patient of intermediate uveitis who's already on treatment, but is still having a persistent peripheral leakage, would you step up your treatment, or would you just label that it's a stable disease and continue whatever is being given to the patient?
So if I compare it, for example, to the baseline for senior angiography, and I see there's no difference in terms of the peripheral vascular leakage, I would definitely still label it as active disease, and I would increase. If I see that there was tremendous decrease compared to baseline when the patient was not treated yet, then I may, it depends again how much. If it's just a little bit, I may observe, otherwise I would increase treatment as well. Yeah.
And sometimes it's a matter also of chronicity, depends on for how long the inflammation has been going on. So I have patients on maximum therapy, and even with Ozurdex, the leakage sometimes doesn't go away. So I also wonder, is it really inflammation, or the blood-retinal barrier is so now compromised that it will never go back to normal? So the chronicity is very important.
Yeah.
So,
you're not only treating the leak during follow-up, you're looking at the visual acuity, the presence of any cells, cystoid macular edema, disc edema, any signs of worsening. So if there is some leak which has always been there, I would just keep him status quo.
And Dr. Francisco, you beautifully showed the application of ICG in toxoplasma. I think quite a few of us really don't land up doing an ICG in toxo. So, I mean, how relevant do you think it is to be performing ICG in a case of toxo?
Zero. No, but so there really are, I love the paper by Herbert. There really are satellite foci. But we are able actually to get them with OCTA. So I don't do ICGA in toxo anymore, but it was really helpful to understand better the Kyrie inflammation, and that's inflammation inside the vessels. It's not like sheathing. But no, I actually don't do ICGA anymore. And we are finishing the paper to demonstrate that the OCTA is able to catch those foci with the same accuracy as ICG.
Now, Francesco, I have a question here for you. You look at toxo and you know it is toxo, and you do OCT, you see those cells in the vitreous, and you see retinitis, and you see all that oval spots and everything. So you know it is toxo, and you know you got to treat it. Would picking up an additional satellite lesion on ICG going to make a difference in the management protocol for you?
No, it wouldn't. But I think in the future, we should look if those satellite foci are more prone to get reactivations.
I was just wanted to
Francesco,
ask what about
it will be good proposal
yeah.
for AI application to predict. Yeah. You should take it up.
Yeah.
Under IUSG.
Yeah. In terms of prophylaxis versus no prophylaxis in the presence of satellites.
Actually, to that question, Dr. Francisco, Dr. Manfred has actually said that if you see peripheral lesions on ICG in a case of toxo, is it having any additional consequences then?
No, I mean, I don't think so. It's the matter we don't have enough follow-up. But no, for now, not in the way we treat. Probably, as Marion was saying, in the prophylaxis, if we learn that those foci are more prone to reactivate, then yes, in the prophylaxis in the future.
So another question for all the panelists, actually, that which imaging modality would be the best when you are...
Lymphomas. I think Manisha's internet is breaking in between. So Ranju from Nepal is asking, what would be the best imaging modality for intraocular lymphomas? And we can start with Mohit.
Yes, absolutely. I think it depends on what kind of stage of the lymphoma you're seeing, whether it's just the vitreal involvement, the very early ones, and we're talking about primary vitreoretinal lymphomas here, or it's the typical, or you're actually not seeing a lot of vitreal inflammation. You're just seeing those typical subretinal yellow deposits, or again you're not seeing a lot of vitreal inflammation and you're seeing those punctate RP abnormalities. I think if the predominance of if the predominant clinical finding is not in the vitreous, and it's actually those subretinal RP deposits, subretinal yellow deposits, and or those the RP disturbances that you see in the clinical setting of a suspected lymphoma, then a fundus fluorescein angiogram along with autofluorescence after a OCT is what would actually help. OCT would actually really highlight those sub RPE deposits, or also the sometimes depending on what stage you catch them, also the subretinal deposits, or you can have other changes as well. And after that, I think the pattern on autofluorescence, which is reversed on FFA, the so-called leopard skin appearance, will show a much wider area of involvement. So I think an OCT followed by AF/FFA would be my goal.
Anybody has anything to add or do anything differently?
What would be the ICG pattern, Francisco? Would you add ICG?
I could try to say something smart, but my earphones were dying and I missed the question.
What we're wanting to know is, would you add in lymphoma workup ICG?
Would you do ICG for lymphoma?
No, not at all.
Okay. There is question for you. Can OCT angio show disappearance of endotheliitis and cryolisis arteritis following treatment?
Maybe not OCTA, but unfast OCT maybe would be the best way to follow that.
Marian?
Maybe arteritis. I mean, if you have occlusion and non-perfusion, yes. And otherwise, I don't think OCTA would be a valuable tool here. Yeah.
Mohit?
There is one paper on, I think if you really have to look at imaging for that, I think there is one paper on adaptive optics of Carlis plaques. I think that would really kind of drive home the point that Dr. Pichi actually elegantly showed in his talk, that it's actually, because in that you can actually make out whether the wall is getting involved, because the resolution of the AO system is a lot better than any of our other imaging modalities.
I mean, what you can see, there was a paper by Spade who showed that if you have vasculitis and vascular leakage, that you can see non-perfusion surrounding the affected vessels, which actually decrease when you treat it. But I think it would be a lot of effort for something we know and we see.
It's more of an academic interest, but it's
yes.
AO would actually show it to you. Whether it would affect or modify what we're doing is a different question altogether.
Yeah.
As a clinician, I think one thing which we'll all like to know is that when we are following a case of toxo, using the various multimodal imaging, ways, when would we say that the lesion is completely healed? Is there any way that we can say that, yes, now we can stop the treatment? And what would be your way of assessing that?
Clinically. I think clinically is still the best way. Then I'm sure Alessandro, when you had the talk by Alessandro, I'm sure he showed you how the OCT changes as the lesion heal. I never do serial FAs. I think clinically is really the best way.
Dr. Marion, anything on that?
I agree. I mean, you just observe it with clinically fundus exam and with OCT.
Dr. Shishir?
After you think clinically it is healed, I would still taper off and decrease the frequency of treatment, but I would still keep it on a once a week or twice a week treatment for 6 months before I completely go off the treatment. I don't know what the others would say to that.
No, I agree. There's another question. I think it's for Francesco. Does granuloma become hyper in the healing phase? Does it suggest full thickness granuloma resolving to partial thickness? I don't know whatever it means, but you got to answer.
So full thickness resolving and becoming smaller means that it's hypo.
Is that why it becoming hyper? What you showed, there are 3 patterns of healing on ICG.
No, it's just my opinion, but I think that when it's becoming hyper in the late phases, it's more of a scar. It's fibrosis contracting, and either the tissue, either the vascular tissue around is catching more dye, or the fibroblasts are catching some dye. But no, it doesn't mean that the granuloma is healing the correct way. It means that maybe it was a chronic granuloma and it's becoming a scar. Personal opinion.
Yeah, you showed that beautiful diagram that it causes the pull, and probably the dye pulls in the choriocapillaris in front.
I'll move on to the next question. One question by Dr. Atul Arora, and he says that would it be useful to correlate the hyperfluorescence on ICG with EDI OCT?
Hyperfluorescence in granulomas? Yeah. So we did it. Sometimes you can actually see a small hypertrophy of the choriocapillaris on top. But I fight with Alessandro all the time. To me, without ICG, finding granulomas on EDI alone, especially if they're small, it's nearly impossible. So we try to look. Some of them, they have an hypertrophy of the choriocapillaris when they are hyper in ICG. But still, I don't know what it means.
So there's another question. Actually, there are 2-3 questions by Dr. Eduardo. He says that in mutes, how do you compare the simultaneous autofluorescence and ICG during activity? And which one of these would indicate a diseased RPE?
Well, both of them, because at the end of the day, autofluorescence comes from RPE cells. And if they are thickened or there's a mottling, then sometimes you get some hyper. And ICG, we showed it before, when the RPE cell is not, it's sick or it's hypertrophic, it doesn't catch the dye. So they correlate very well. We showed it in the paper, and yeah.
I mean, it may be also additionally due to the unmasking from the hyperfluorescence of the RPE.
I think Manisha's voice is breaking again. Mohit, would you like to comment on this?
I think Dr.
Manisha, you need to mute yourself.
I'm sorry?
Marian's voice is, somebody's voice is breaking.
No, I just wanted to say that maybe it was me. I don't know. The hyperfluorescence.
That's okay. We can hear you now.
Okay, that the hyperautofluorescence can come from, and immutes can come from the RPE, but it may be also seen due to the fact that you have photoreceptor attenuation and these dots and spots, and then you have a transmission signal or more transmission signal coming from the RPE, which just goes through and is captured.
Yeah, I think the hyperautofluorescence is different. Cause is different on the dots and on the spots. There are different. Yeah.
I think a similar thing is also true for PIC, which I think most of us now believe is a misnomer. It's no longer a choriocapillary, right? You know, the OCT has shown us very well with the classification. I think this is keeping in mind, you know, the question that was asked about what's going to pick up that so-called activity in mutes. I think PIC you can kind of club in the same category as far as monitoring disease is concerned. I'm not saying mutes and PIC are the same thing. But you know, I think the OCT along with the autofluorescence will be my bets to pick up, you know, the activity. Although of course in mutes as has been shown, I think autofluorescence along with the ICG is the way to go. But PIC is similar, and with the unmasking because of that presence of those things on top of the RPE and the active stage actually being actually being hypo, which is contrary to all of our other choroidal pathologies. So I think that is also something that needs to be looked at and maybe wasn't asked by anyone, but just I wanted to add of my own.
There's a question for all of you. Do you have experience of ICG in SUSAC?
No, I actually, when I was with Sunil,
You have made the entire India very interested in ICG. So.
And if Francesco hasn't seen it in SUSAC, none of us have in ICG.
Yeah.
In SUSAC. So
I know.
So there's another question for all of you, that any hints about likelihood of metastasis on any imaging modality? I mean, when you are looking
clinical.
for metastasis, what would be your best imaging modality to locate that?
I think I think if you have paraneoplastic manifestations, those would be different. But actually talking about metastasis, that would be different. So if you're looking at a paraneoplastic, let's say a dump kind of a picture, or you're looking at a vitelliform submacular deposit, the autofluorescence clinical imaging, yes, but and also the OCT would be very, very helpful, as opposed to if you're looking at a choroidal metastasis, which is directly kind of coming from the tumor. In that, you would definitely have a mass lesion. Ultrasound should help, and angio may, or a fluorescein angio may or may not be contributory if you get that mottled kind of appearance on top. But the ultrasound should show a mass lesion, as opposed to some of the other paraneoplastic ones like dump or CAR,
autoimmune
which I think electrophysiology would come to your rescue along with OCT and be a lot more diagnostic, given that antiretinal antibodies aren't that easy to come by. So I think it's quite a big answer to that metastasis or paraneoplastic or whatever.
Dr. Vishali, would you like to add something to
No,
that?
I think for both the things, more important than imaging, you need the clinical acumen to suspect it. That's the most important thing. If you are suspecting it, then as Mohit said, if it's a mass lesion, you do basic ultrasound, look at the characteristic, look at the rest of the body, look at the features. But if it is something you're looking for, those CAR, MAR, dump, and cancer-induced retinopathy and all that, autoimmune, then of course the autofluorescence electrophysiology. But the clinical, to me, will be the most important thing in all these.
I think, Vishali, in all of this, all the multimodal imaging will be required at baseline. Then one can keep on choosing what one wants to do in follow-up. But when you are taking a baseline situation, you would like to do everything, including ICG if possible. And then maybe you can follow it up with Octa or whatever you want to do. And only in dilemma situation, you can repeat the entire stuff.
But then we may end up, I'm afraid, and I love multimodal imaging, but I'm afraid sometimes we end up like those uveitis specialists or the lab for every kind of lab, and then they get confused. So clinical.
I will not do. I agree. I will not do.
OCT on the lesion, you see it's probably EDI, then get an ICG as well. If not, I don't see the point of an ICG. And of course, a B scan. It's with A scan as well. It's very important.
Yeah, I agree. I would do a fundus exam, and if I see the lesion, I would do an ultrasound and a swept source OCT or an EDI OCT, that I'm going to be able to follow the lesion death when it's treated. Yeah.
So I think, Dr. Francisco, you've raised a lot of interest in the Chirelis plaque, and I think quite a few of us have realized that it's actually inside the artery. So does that mean it will be having the risk of causing any kind of a vascular occlusion, and should we be really adding on some kind of anticoagulants to a patient who is having these?
No, no, because it's an endothelitis, just inflammation of the endothelial cells. So there's not actually, we call them plaque, but it's an endothelitis. And if you looked at the OCT I showed, and there are more OCTs in the BJO paper, the lumen of the artery is completely free and unchanged. So it's just an inflammation of the endothelial cell.
Right. So I think we are done with all the audience questions.
Yeah,
so,
I think they all need to give one last message and then we are done.
Yeah.
You have more questions? I don't know.
No, I think we are done with the questions. So maybe
they all have to give a message.
Yes. Dr. Francisco, we'll start with you. Any take-home messages at the end of the session by you?
That's tricky. So my take-home message comes from my experience. I used to not love ICG, but the curiositas, so the willingness to learn more, made me love it a bit more, ICG. So we can always learn something new by not closing our minds towards something we don't really appreciate 100%.
Great. Dr. Marion?
Hard. So maybe I think we have to differentiate what is important in daily clinic and what is interesting in an academical setting. I think we can learn a lot if we look at each individual image modality, and if you want to understand what's going on, then the more image modality you have, the better in order to understand the pathophysiology of the disease and the development. However, when it comes to observing the patients and follow the patients, sometimes less is more. Yeah.
Dr. Shishir?
I think one take-home message will be that the last word is the clinical acumen and the clinical findings. One must correlate that you are seeing cells and flare. You should not be treating a masquerade like a uveitis. So I think the clinical science, as much you may depend on autofluorescence and color photo, we should not treat the imaging. We should treat the patient. We should treat what we are seeing clinically.
Dr. Mohit?
I'm just going to sum up one small point. I actually got a message from one of my anterior segment colleagues who's a private practitioner and has actually logged on to our webinar, and he's actually asking, do I need to get ICGA if my posterior segment colleague actually wants it? So maybe thing to all the general ophthalmologists and the non-uveitis people who've logged on, and firstly thanks to them. I think secondly, I think the answer, as Dr. Pichi also mentioned some time back, is no, it's not mandatory. But at any point in time you see, and this is absolutely general, multiple yellow spots at the back of the eye, and what you feel is not according to what you, it's not a pattern that fits you, and you do not have access to ICG or OCTA, please send that patient over to somebody else who has that facility. Other than that, I think for most other uveitic lesions, including posterior uveitis, I think ICG is not mandatory. It's a small subset, niche subset. But if you come across that, and again, I'm not using the term white dot syndromes, it scares a lot of people. But if you see yellow, creamy white lesions all over, or maybe a few, and either the patient was treated somewhere, came to you, did not get better, or is not fitting a pattern what you, according to your clinical or academic acumen, feel is a particular disease, please send that patient over to a facility that has. Other than that, no.
Yeah, we don't want everybody in India buying ICG and start doing it.
Absolutely. Absolutely.
Actually, interpretation of ICG is a little bit different, laborious and time-consuming.
Absolutely,
it's not just about doing it or having the machine. No. It's about interpretation of what.
Because you keep seeing those dark spots, and they could be anything.
And economics come into it as well, man. Because when you need a CSLO based system, flash ICG, I think all of us would agree, is kind of left the building. So it's also expensive for a lot of people.
And during COVID time, the contact time doing the procedure is prolonged, so there are issues.
Absolutely, ma'am. It has
So I think we have a compliment from Dr. Nikita, who found all the talks very amazing. And I think at the end of the day, we all agree that it's basically your clinical examination, which has to be in detail. And probably then you land up using the various imaging modalities just to confirm what is your differential diagnosis, and you start excluding them one by one. So I think that's the take home, because every investigation costs money to the patient, and we have to be selective in choosing them. They have to be informative, and they should be adding to your clinical judgment and decision. So thank you so much. I think we've had an interesting session, wonderful talks by Dr. Francisco and Dr. Marion, and active participation by the audience. I also thank Dr. Shishir and Dr. Mohit to have added on to the session with their expertise. So thank you so much for taking out your time and all the effort. Thank you, Dr. Vishali. And we all look forward to the next month's session. Stay safe and stay healthy. Thank you once again.
Thank you, everyone.
Thank you
Great
very
weekend
much.
and stay
Thank you
safe.
so much. Have a great
Bye,
weekend.
Marian. Have a great
Bye.
weekend.
Thank
Bye,
you.
Francisco. Bye,
Bye.
Mohit,
Thank you,
Shishir.
ma'am.
Thank you very
Okay.
Thank you.
Okay,
much.
Manisha. Bye.
It was
Bye.
really lovely
Thank you.
talks.
Thank you.